5FU, and it mimics the idea of continuous infusion 5FU, and it was approved based on a phase 2 trial where it resulted in response rates of about 20% and time to progression of 3.1 months. So to give you an idea of where the bar was when this was approved in the late 90s, chemotherapy drugs that are being tested today have a much higher bar. There was no survival benefit. This was not a randomized trial. So there's all this discussion of the FDA saying we have to have a survival benefit to prove a new therapy. That wasn't the case, 10 years ago. So back to now, I wanted to just mention to you very quickly about another patient. Our patient was HER2 positive, but what if we had a patient very similar to this, but they were HER2 negative, and she were actually developed metastatic disease, then what would we consider doing? So in this particular patient, similar story, ER positive, but this time HER2 negative. She has metastasis in her bones. So in this case, she actually goes on to an aromatase inhibitor. It's quite remarkable how a patient who wasn't able to tolerate an adjuvant hormonal therapy, once they have metastatic disease, the pills seem much better than chemotherapy. And then a typical course is they'll be on this hormonal therapy for somewhere between 6 and 9 months, and then they'll develop metastatic disease, often in the liver, or they'll develop progression in the bone. And then they're switched on to other hormonal therapies, and then they end up finding their way to chemotherapy. And each time they respond to a treatment for several months. And so, as a medical oncologist, our challenges are to decide when should they be on a clinical trial, what other chemotherapy drugs are the most important, and what biological therapies are available. And so one of the most exciting biological therapies are the anti-angiogenesis agents, and for the sake of time, I'm just going to skip through these few slides to show you some data that was presented that's led to the approval of Avastin. So, one of the more controversial agents because, again, in this trial there has been no survival benefit demonstrated. So this is a clinical trial of patients that were receiving either Taxol as their first treatment for metastatic breast cancer or Taxol plus Avastin. It was a trial of about 700 patients. And you can see here some of the data about these patients. And you can see here that patients who had measurable disease, addition of the bevacizumab or Avastin improved overall response rates in patients who had metastatic or measurable disease and extended progression-free survival by about 5 months. So this is what led to the approval of Avastin. No survival benefit has been demonstrated. However, I can tell you from personal experience, I think it really has made a difference in terms of the ability for us to carry people along who have hormone-resistant disease who needed to move on to chemotherapy. For the sake of time, I'm going to skip through some of these slides and just go back to our HER2 positive patient. So what could she do now that she's developed a metastatic recurrence? She has visceral metastasis, so I'm thinking she's actually a candidate for chemotherapy. So we could restart chemotherapy with one of these different chemotherapies plus trastuzumab, or she could receive an alternate biological therapy, capecitabine plus lapatinib, or she could participate in a clinical trial. And I have some data on the clinical trial that it got the approval for lapatinib, but for the sake of time, I'm just going to mention we'll go forward to a clinical trial compared capecitabine, again, Xeloda, the oral chemotherapy that I talked about previously, alone or in combination with lapatinib for patients that had HER2-positive disease that had progressed on an anthracycline, a taxane, and trastuzumab. And the data show that addition of this biological therapy improved progression-free survival by about 4 months. And so this is the data that got approval for lapatinib in the metastatic setting. And so that's what the patient decided to do. We went on to lapatinib plus capecitabine, and in the typical benefit, in this case, she did well for about 9 months, eventually developed progression of disease, and so then we have to make another assessment. What is important in terms of her quality of life? Are we going to consider a clinical trial? What kind of choices are we going to make in terms of IV therapies, frequency of treatment? And then we have to take into consideration particular issues associated with HER2-positive disease, like monitoring cardiac function, increased risk of brain metastasis.
And so just too far away from it. What's your interpretation of the discrepancy between generating improved progression-free survival and not improving overall survival?
I think there's too many treatments down the line. So back in the pivotal trial for Herceptin, when patients got chemotherapy plus Herceptin or chemotherapy alone, there weren't nearly as many systemic therapies optional for the patient. There was no lapatinib, so adding Herceptin to chemotherapy resulted in a survival benefit in that pivotal trial. But I bet if that trial were repeated today, you know, patients would go on and receive second line, third line, fourth line Herceptin. Patients who crossed over and got Herceptin outside of the study would probably do just as well. So I think that the days of being able to demonstrate a survival benefit looking at a first line or second line treatment in metastatic disease is pretty rare. Now the PARP inhibitor trial in the randomized phase 2 seems like they were able to do that, but again, it's because these are patients who are particularly bad off and they don't have a lot of other options down the line. So if you can actually gain someone a 6-month progression-free survival benefit early on, and they're only going to live 2 years, well, that's going to be pretty substantial. But if you have a patient population where you're gaining them 4 or 6 months up front, but they're going to live 5 or 6 years, I think you can make up each of those months down the road. That's fine. That's my theory. And so just to finish up, I just had some thoughts about systemic therapy. In summary, and I think that you know, being a medical oncologist, there's a lot of art to it, and there's no way I could possibly cover it comprehensively in 30 minutes. So, no. For the sake of time, then, I guess since Shelley's not here, we guess we'll transition over to Naomi's presentation. And I sense because I actually need to leave to go home to my kids, I wanted to see if people had any other questions before.
I have one with Jamir, and quick, and that is just where does radiation fit into all this?
So typically the order of events would either be the patient does neoadjuvant chemotherapy and then surgery, and then would go to radiation if they need it, or if they do surgery first, they do surgery first, then chemotherapy, then radiation. And Naomi will talk about, I think probably will mention some of the data where they looked at sequencing of these things, of radiation either before chemotherapy or after. There's been at least one trial that's looked at that. But just traditionally, the radiation is kind of the last thing that people do.
The
Last, you know, so after surgery and chemotherapy, what order they do it in.
some people are not.
Yeah, right, not everybody.
It's really to come to the other side of
It
the
didn't really
picture.
matter, but you would think if somebody had a
Since
high
there's the
risk
better
of
side, it
event
goes down.
positive margins
So,
or
I don't
things
know.
like that, you might want to come in earlier with the radiation
The
therapy
next
for the local
always
therapy.
question.
But otherwise, our concern is controlling the distant mets if they're high risk. So, like local therapy.
Are there any
Maybe I
other
can switch
questions?
just to
I
see.
mean, I know it's really, it's almost embarrassing to try to pretend that I could cover anything, you know. But I hope that gives a flavor of, you know, what we do.
Well, I did something unusual for me. I mean, like I just tried to, that you guys are scientists and you might want to see some science about the radiobiology or how we can look at vaccination and things like that. So I kind of went back to notes that we would do for the residents and even tried to just, you know, if I didn't know anything about radiation, what would I like to do? Okay, so I did it in 2 parts and actually did it in 2 different programs. So this is, I'm going to do the radiobiology and then I'll go into more about like data and techniques of radiation, things like that. So, how much dose to destroy cell function? That was our goal. Actually, that's 10,000 centigrade. And that's way above what any radiation oncologist is willing to give, because that would basically bore a hole into somebody's chest wall that would not heal. And that's why we don't like to re-irradiate people. We usually go to like 5,000 centigrade, and we don't like